Good afternoon, everybody. Thank you for taking a minute to join us here with the Tennessee Department of Health as we give you an update on what's going on with COVID-19 across the state of Tennessee. I'm Dr. Michelle Fiscus. I'm a pediatrician and the medical director of the Tennessee Department of Health Vaccine Preventable Diseases and Immunizations Program. And with me is Dr. Amelia Keaton, who is a pediatric infectious disease specialist and also the medical director of the Hospital-Associated Infections Program here at TDH. We're going to go through some updates on what's going on across the state right now with coronavirus. And first I want to go through a couple of housekeeping things. Can you advance the slide for me? So this is a very rapidly changing situation, as you are all aware. And so by the time we end this conference today, some of the guidance that we've just spoken about may have already changed. So we encourage you to check with our website, which is tn.gov/health, and click the updates on the ongoing coronavirus outbreak bar that's in yellow at the top of the page, or go to cdc.gov/coronavirus to get the most updated information. But what we're presenting to you right now is what we know is the most updated information as we're talking to you right this minute. All of your lines are muted. We have several hundred people on the call right now, but we will take questions through the chat box. So as questions come up, if you want to enter those into the chat box, we'll leave plenty of time at the end, and Dr. Keaton and I will try to address as many of those as we can. I'm going to turn it over to Dr. Keaton, who's going to go through the current status of things, and then I'll be back to talk some more about what you're doing or what you can be doing in your practices.
Great. Thanks, Dr. Fiscus. So again, I'm Amelia Keaton. I am in charge of the Healthcare Associated Infections Program. Just wanted to make you aware of a few resources that are getting regularly updated on our website, as Dr. Fiscus already mentioned. So every day by 2 p.m. we are trying to update our confirmed case counts of COVID-19 on our website. We're also breaking those down by county and also trying to provide ages for all of the confirmed cases if they are available. We have also heard you loud and clear that we need to make more or make available what we know about testing assessment sites in the state, and so we are updating our list of places that are able to offer COVID-19 testing, and that is also updated regularly on our website as well. We also have, we definitely understand that PPE or personal protective equipment is at a premium, and that most primary care providers don't have adequate personal protective equipment at this time. We unfortunately at the state level don't have PPE to distribute. So we are asking that all providers, both outpatient and inpatient, need to do what you can to protect yourselves and still see patients. And some of that involves conserving PPE where able, and some of it involves just simple measures such as distancing yourself from your patients, trying to minimize the number of folks in your office who come in contact with patients who have symptoms. And also, keeping up to date with guidance from CDC and other sources on how to conserve PPE and preserve what you have. We also know that testing at this point is still not adequate. It has expanded dramatically over the past few weeks, but it is still limited by lab capacity, the reagents needed to collect the specimens and perform the testing, and also the supplies for specimens in general. We know that hospital emergency departments and urgent cares are overwhelmed by the number of patients that they have seen and that are requesting testing, and that not only us at the state level, but also local and regional health departments are getting overwhelmed by the questions and situations that they're being asked to deal with. In terms of how the Tennessee Department of Health is responding, we've set up an incident command center, and that's been active since January 15th, so we are well into our third month at this point in that structure. We've set up a public info hotline, or public information request line rather, that runs every day from 10 a.m. to 10 p.m. 7 days a week, and you can see the number for that as well. We've answered, and that line has answered over 3,000 calls in one day this week alone. I would try to give you a more accurate number, but that's changing, as you can imagine, by the minute. And even though our capacity is 300 a day, we are trying to triage and get back to as many callers as possible. We are also working to set up an additional public info line, and that will hopefully be operational soon. We will provide the number as soon as we have that available. We have a call center for clinicians who need clinical or diagnostic support, and that's available from 8 a.m. to 8 p.m. 7 days a week. We have answered hundreds of calls through that line. Overnight, we have an on-call physician or other provider who can answer public health emergencies. Although we are asking that if you are simply requesting advice on testing, to please try to delay that into the morning because we know that those specimens can wait to be shipped to our lab or to other facilities. In tandem with what we are doing, we know that the providers out there are doing a ton of work on the front lines. And so some examples of what we have seen and what we've heard from you all are developing new standard operating procedures, postponing any elective visits or procedures in your office to help both conserve your workforce and also conserve your supplies of personal protective equipment. Folks are doing more telehealth visits, I think, than they've ever done before, and we are definitely supportive of this. We are asking, and most of you are already doing this, for providers to post signs asking patients to call first with any symptoms that they're having, and for patients at your practices to put a mask on as soon as they get to your practice if they have respiratory symptoms, to help protect those in the waiting room and your staff members. If possible, some facilities are also performing testing outside of their offices. And we know that many are also bringing patients immediately in through alternative doors to minimize the contact they have with folks in the office. And then finally, we know that some practices are also dedicating staff to deal with folks with respiratory illnesses to help minimize the exposure to everybody in the office in general. So I think it's also important to take a step back to review some of the terminology for COVID-19 testing. I know that there have been a lot of different things in the news that folks have heard. So in terms of testing kits, we've heard a lot of folks asking about, they don't have testing kits in their offices, they don't have the ability to collect these specimens. And in a lot of cases, this actually isn't true. So the term testing kits has been used by CDC to describe the actual laboratory reagents to test for SARS-CoV-2. And in case that looks confusing, that is just the virus that causes the illness COVID-19. These kits are not unique to, these kits, or the reagents are things that are sent to laboratories. They're not actually what's sent to provider offices, including healthcare facilities. Rather, clinical specimens are collected through supplies that should already be available in your practice or that you are likely already familiar with. So we are most frequently asking for folks to perform NP or nasopharyngeal or oropharyngeal swabs. If a patient is more ill, we can request lower respiratory specimens or nasal washes or aspirates that are then sent to laboratories to look for that specific virus. These usually are collected using a synthetic swab, which is then placed in viral transport media, or we just received word this week that we can also do the testing with e-swabs in Amy's media, and that's a recent development that hopefully will alleviate some of the shortages of supplies of viral transport media. With regards to patient assessment and testing, I think this is something that is improving, but I do want to stress that the majority of clinical facilities and providers can safely assess, triage, and treat most patients with COVID-19 in most clinical settings. Unfortunately, local public health, cannot test patients in most settings, but you should feel empowered to do that because it is something that we have good, strong evidence can be performed in the absence of a negative pressure room, which I think was a common misconception early in this pandemic. It is not appropriate if a patient doesn't need emergency medical care to send them to the emergency department for testing. We are asking for folks to stop doing this if at all possible. We also don't currently recommend that asymptomatic patients who don't have symptoms that would be consistent with COVID-19 be tested under any circumstances, and that includes if they were in contact with somebody who was known to have COVID-19. And finally, as more commercial labs have come online, it's not necessary to call the Tennessee Department of Health anymore to request permission or approval for testing. I think that is still necessary if testing is being performed through our state lab. But hopefully by removing that precaution for commercial labs, that will free up time on your end to really focus on patient care instead of trying to hunt us down to get approval for testing. In terms of the kind of algorithms that we're recommending that providers take when doing testing for COVID-19, common things being common, we still ask that you consider sending a regular respiratory viral panel and flu testing before considering COVID-19. If you are testing for COVID-19, we ask that you place the swabs collected in viral transport medium, label it with the patient name and date of birth, and if possible, if the patient is not in a high-risk group or is not critically ill, we ask that you consider sending that specimen to an outside lab unless you, again, feel like that patient needs more urgent testing that can be performed at our state lab. If the patient is otherwise clinically stable, though, they can be sent home to self-isolate until those results come back. And if you receive positives from commercial labs that perform the testing for you, we ask that you notify us of those results as soon as you get them. In terms of commercial labs, we have 3 of the most commonly reported ones that are used here, although this list is ever expanding. To access these labs, you do not need to call us prior to order testing, but you need to make sure that if you're going to use one of these commercial labs, that you collect the specimens and transport them in the manner that they recommend. We also know that at this point, many of the commercial labs are only working with those providers that already have contracts with them, and so that's something to consider when selecting who you pursue your testing with. But we are also, we do receive a lot of calls about the protocol for sending specimens to these commercial labs, and we really ask that you call those labs yourself to try to get those procedures, because we don't necessarily have all of the ones for each lab that does the testing. Again, just to reemphasize that positive cases are immediately reportable to us. We do try to collect as many of those results as possible from commercial labs, but it is possible that you will receive results before we do. And so in order to assist with our public health response and contact tracing, please call us if you do get those results. You're also welcome to fax them at the number there, or call your local health department, who can then get in touch with us. In terms of the types of facilities that are doing these specimen collection, so most of the clinical labs, if not all of the clinical labs, or healthcare facilities that are able to do the tests, and these, we are hearing more and more that large healthcare systems have developed their own tests outside of commercial labs, are still limiting those tests to their own patients or to their employees. And so the criteria for testing at healthcare systems or clinical labs is really determined by that facility. As I mentioned earlier in the talk, there are more and more alternative testing sites. You can access those on our website. We are updating those as we learn of them, and the website link is on your screen here. In terms of prioritization of testing at the Tennessee Department of Health lab, our capacity remains limited. It has expanded dramatically since our testing came online at the end of February. But so that we can try to provide results to the highest risk patients, we are asking that at this point you focus really on the following patient groups for testing at our state lab. So those would be individuals with direct contact with a confirmed COVID-19 case who are currently symptomatic with symptoms that would be consistent with COVID-19, individuals who have symptoms and have traveled to a high-risk international or domestic location that has evidence of widespread community transmission within 14 days of their symptom onset. And we know that this list is rapidly expanding to include most states at this point. We ask if patients are pregnant or have a severely immunocompromising condition that you send those specimens to our state lab for testing, or if you have individuals who are in high-risk occupations. So that would be any healthcare worker and anyone who works with elderly or other at-risk populations. And then finally, those with severe pneumonia or acute respiratory distress syndrome without another etiology. And then finally, another group are those who are uninsured or otherwise unable to get testing through their regular provider. So in terms of what we need at our state lab for specimens coming to us, we ask that providers collect a polyester swab from the nasopharyngeal or oropharyngeal sites, place those swabs in viral transport media, or you can use a polyester swab in sterile saline. This is a new development this week that was released by federal agencies, or kind of as mentioned earlier, an e-swab in Amy's media. And with that, I will turn things back over to Dr. Fiskus.
All right, thank you. So when you're working with patients who are suspect patients or those who you've ordered testing on, it's important to give them certain guidelines so that they understand what to expect. So the first is to make sure that they understand what the general turnaround time is going to be for that testing. If you're sending a specimen to the state public health lab because you have someone who's in one of those high-risk categories that Dr. Keaton mentioned, then that turnaround time is going to be around 48 hours from the time that the lab in Nashville receives the specimen. So if you get a specimen today, you're sending that by FedEx this afternoon, it will arrive tomorrow, Saturday, in the state public health lab. And then by the time that is processed, it will probably be Sunday before that is able to actually be run, and then that would be resulted Sunday or Monday to you. So make sure that they have a realistic expectation. We've had reports of really varying times from the commercial labs for turnaround, anywhere from 3 to 5 days to some labs where we know specimens have been sent out and it's already been more than a week and results have not returned. So you may want to contact your local lab to find out what their expected turnaround time is going to be. Many of those specimens are being shipped to one national location. For example, Quest sends all of their labs to be processed in California. So you have to add in the extra time for that. And if there's only one facility in the country, then you may see some delay in getting all of those specimen results back to you. If you have a positive patient, you need to let them know that it may be a couple of days before they hear from public health at this point, especially in our regions like Davidson County and the Mid-Cumberland area, which are the counties that surround Davidson County. They still have the bulk of the patients that have been identified as having COVID-19, and so their public health capacity to do contact investigation is very much overwhelmed at this point. So let them know that they need to be in isolation at home. The new recommendation that was just updated a few days ago is that isolation for positive patients needs to be 7 days plus 72 hours from the time that they feel well. So if they are feeling well by day 4, they can come out of isolation after day 7. If they are still symptomatic and not feeling well at day 7, then they need to be in isolation through day 10. The one caveat to that is lingering coughs are not included in that time frame. So as long as they're feeling well, even if they have a lingering cough, they can come out of isolation at 7 days or plus 72 hours from when they begin to feel well. Please ask those positive individuals to start contacting their close contacts and informing them that they need to self-quarantine. And that recommendation for non-household contacts is still 14 days from the last contact with that positive individual. If they're a household contact, that 14 days doesn't begin until that diagnosed individual has returned to wellness. So if you have a household contact of a positive case and that positive case doesn't start feeling well again until day 6, then that family, those household contacts are quarantined through day 20 from when that individual first became symptomatic. So 14 days from the time that the case returns to wellness for household contacts. On the screen, there are several guidance documents that you can see links to. These are all on our website. Again, that's www.tn.gov/health. And if you click on the bar at the top that talks about updates for the current outbreak of coronavirus, it's the orange bar. Click on the orange bar, scroll to the bottom, and you'll see a lot of blue bars that have varying guidance there, and these are under the providers folder. So there's one for guidance that you give for people who have testing that's pending and what they should be doing, one for people who have tested positive, and another one-pager for people who are close contacts of someone who has had a positive test. The PPE recommendations are still the same, and we've got a grid that you should see on your screen for that. Basically, if you are in an office and you have individuals who are working for you that can keep a distance of 6 feet or more from a patient, then they really don't need to be in any kind of PPE. But once you get within that 6-foot range, you really have to have, at a minimum, a surgical mask or an N95 mask on. N95s have not been widely available, and so surgical masks are often the best that we can do in those situations. Those individuals who are going to have direct contact, so in-person touching, with an individual who's suspected of having COVID-19 need to be in full PPE, and that's eye protection, a face mask, a gown, and gloves. There has been guidance from CDC that if there's a healthcare professional who is in direct contact with someone and has everything but the gown, they will not be quarantined because of that contact, but they will be asked to self-monitor for symptoms and then self-isolate as soon as they were to develop any kind of symptoms that would suggest that they may have been infected by the virus. So surgical masks are fine as long as you're not suctioning or intubating or otherwise doing some kind of procedure that puts you at risk for aerosolizing secretions from a patient. So pretty much anyone in an ambulatory setting is going to be okay with just a surgical mask. If you only have one mask available to you, put it on the patient. That's at least going to provide some protection. If the patient is masked and you are also masked, then you should be pretty comfortable that you're not going to become infected with the virus, even within that 6-foot range. You may have to come up with some alternatives to surgical masks because they just have not been widely available. So you can get bandanas. I have seen reports in other countries of people using diapers. They have handy Velcro side tabs that can be sometimes stretched around the head. I've seen people in motorcycle helmets. Anything that you can do to put a barrier between someone's respiratory droplets and your face can be something that's used to help protect you. Maybe even fashioning something with layers of tissues and gauze can be something that can be used over the mouth and nose if you don't have access to masks. Obviously, these are not FDA approved strategies, but sometimes necessity is the mother of invention, and you have to do what you have to do to be able to make sure that you're as protected as you can be and that you're protecting those people who are in your office. Gowns are also not readily available. Most private offices do not have disposable gowns, but you could use patient gowns that you wear backwards, that you launder between patients. You could use contractor bags and slit them down the long way, make armholes and roll up your sleeves so that your clothing is not exposed. You can use your lab coats or other combinations of pieces of clothing that you can don on and off and then launder if you don't have an alternative to using anything else. Again, if you're a healthcare worker and you're in direct contact with a patient who turns out to be positive for coronavirus, you would not be quarantined for not having a gown on. As long as you have gloves, eye protection, and a mask, you should be adequately protected, but you would need to monitor for symptoms. If you don't have gloves in your office, you can try getting food service gloves. I was on a call yesterday with someone who said there were plenty of gloves at Kroger by them for food service use. Those very flimsy disposable gloves are still a barrier between you and that person. Could you use bags, zip type bags, grocery bags? And really, the danger with hands is having secretions on them, and they're easily washed. So if you do have contact with bare hands, make sure you're washing really well with soap and water and friction, at least 20 seconds, and that should help eliminate those issues. If you don't have access to eye protection, do your kids have sports goggles or swim goggles or construction goggles? Does the local high school maybe have a chemistry lab and they're all out of session and they've got a plethora of safety goggles there that perhaps could be borrowed? Again, anything that you can do to protect your eyes from any kind of splatter or respiratory droplets is helpful. So there are documents on our website for conservation of PPE, and there are also documents that are similar, and actually some more information on the CDC websites also about conservation of PPE that might be helpful. Please make sure that you're having a very strict policy in your office with respect to your employees. So it is, it is in our DNA, I think, to come to work even when you don't feel well, because you feel a responsibility to your patients, that this is not the time to feel that kind of responsibility. So if you are not feeling well, you need to be home. And if your employees are not feeling well, they need to be home. And they need to understand that you encourage that in order to protect everyone. So no one should be coming to your office as an employee if they're not feeling well, and they should be remained at home isolated until they feel well for 72 hours. So that sore throat might be kind of fleeting, but they should mark out 72 hours just to make sure that they're not having some of these symptoms that seem to kind of come and go with COVID over the first several days of their infection. That may mean that you have to close your clinic down for a couple of days, and we understand what a hardship that is. You have employees that you need to pay, you have patients that you need to serve. But again, for the greater good, we're asking that you be proactive and that you not put people at risk. There are other providers around. It's difficult for all of us, but if you're in a position where you're exposing folks that are coming into your office, then that just contributes to the domino effect that we're seeing with this. In general, again, make sure you're washing your hands for 20 seconds at least under warm water with soap. If you don't have that available, you can use hand sanitizer. That needs to be at least 60% alcohol-based. Remember to practice social distancing. Dr. Keaton and I are a little too close right now, and that's because of the camera that we're in front of, but you should be trying to maintain a distance of about 6 feet between you and anyone else. So if you are going to a mass gathering, hopefully you're just not going to a mass gathering, but you should be able to have at least 6 feet between yourself and anyone else that would be at that gathering. If you're in a small enclosed space, like public transportation or a theater or an elevator, you want to try to limit those exposures as much as you can and avoid non-essential travel. We're probably going to see more states that are moving to lockdown situations, and so if you're traveling outside of the state, it's quite possible that you could end up in a quarantine situation for 14 days. Just stay home, work from home. We obviously are not practicing what we preach because we're here at the State Health Operations Center, and we have a small crew of people here that are working to try to continue to address the pandemic from the state level. But all of the rest of our employees are now at home working an alternative work site situation. If you want to go outside, that's great. Go for a walk. Just don't be within 6 feet of someone else. So I wanted to run a scenario with you just so that you could have a good understanding of the implications and where your missed opportunities might be to avoid having a problem in your office. So let's say that a patient presents to your office and they spend 20 minutes in your waiting room, and then a nurse calls the patient back and takes vitals in the hallway, and then takes the patient to a room and then gets a history that the patient has not felt well for the past few days and has had fever and cough. The nurse then put a mask on the patient and left the room. A physician or other provider comes in wearing a mask, examines the patient, and decides to submit a test for COVID to a commercial lab, and the patient is appropriately sent home to self-isolate. And then 5 days later, you're notified that that patient had a positive test. So what do you do now, and how does that impact what goes on with your office over the next couple of weeks? So first off, anyone who is a positive case needs to be home and isolated for 7 days, or for a minimum of 72 hours from when they return to wellness. And their household contacts are quarantined for 14 days from the time that case returns to wellness. So that will be more than 14 days in quarantine if you're just now seeing that patient. All of the waiting room contacts that were in contact with that patient who were within 6 feet of them for more than 10 minutes will need to be contacted and quarantined for 14 days. The nurse that was taking care of that patient who was unmasked is furloughed and quarantined for 14 days. The provider is not furloughed because both the provider and the patient had masks on during the encounter. So that saved your provider from having to be furloughed for 14 days. Any patients, if the patient lingered in the hallway while they were getting their vitals checked for more than 10 minutes, then anyone within 6 feet of that patient also needs to be contacted and quarantined. And the way that you can avoid having to have that kind of mass contact from your office to quarantine folks is to post a sign on the front door of your facility instructing patients who have fever and cough and or shortness of breath to return to their vehicle and call into your office first before coming inside, to meet those patients outside with a mask that is provided by someone who is also wearing a mask and hopefully gloves, to mask any employee who's going to be within 6 feet of a person who has symptoms, to isolate that person immediately in a room with a closed door. Do not leave them lingering in a waiting room. Anyone in direct contact with that patient should be wearing eye protection, a face mask, gloves, and a gown. But again, if a provider doesn't have a gown available, they would not be quarantined. If there was exposure to a positive patient, they would be asked to monitor themselves for symptoms, but would not have work restrictions. And then make sure you're washing your hands and also cleaning all of those surfaces in the room. Everything needs to be wiped down. There's no recommended time period before you can reuse the room. The guidance is that you need to have everything wiped down and that you need to allow time for the air in that room to recirculate. So you can hazard a guess as to how much time it might take for your air to recirculate. That's probably not going to be a scientific response. But the longer you can leave that room open before it's reoccupied, obviously the more you're going to cut down on problems. So again, our website is www.tn.gov/health. And to go to the corona specific information, click on the yellow bar at the top of the page, and that will take you to our corona information pages. Scroll down to the bottom and you'll see blue bars that will provide you specific guidance for providers, where all of the resources that we've shared with you during this call are listed, and you can download those. CDC has the most up-to-date information and guidance, and that is at cdc.gov/coronavirus. And you can see a wealth of information there, everything from how you prepare your office, checklists, ways to contact patients, and pretty much anything you can think of from a facility standpoint, you're going to find there. So we're going to start answering your questions. You can continue to put them in the chat box, and we have several that have come in, and Dr. Keaton and I will go back and forth and start answering some of these for you.
Sounds good. Thanks, Dr. Fiskus. And I will say that even though we are sitting very close together, we are having our temperatures monitored daily, just as a precaution here at the Tennessee Department of Health. We also have lots of hand sanitizer and lots of cleaning that happens every day as well. So let's see what the first question is. So due to patient privacy concerns, how can we tell patients they have been exposed? So I think that this is a situation that probably happens more commonly in hospitals than in outpatient settings. I think that it is still within your power and is considered appropriate to tell patients that they have been exposed. You don't have to provide the name of the patient that they were exposed to. I think at this point it's becoming more and more common anyway, and so it's often hard to determine where the exact exposure came from anyway. But you should still be able to disclose to a patient their risk without having to provide who that risk may have come from.
So Tennessee Department of Health recommendations to cohort patients in an attempt to maximize resources. That would be difficult to do in an outpatient setting because you're likely not going to have results, and you don't want to put someone who has influenza in a room with someone who has RSV and a room that has someone with COVID-19. So In an outpatient setting, you're not really going to be able to cohort them, and the recommendation would be to put them in their own room to isolate them with a closed door. In hospitals, I'm sure they are having to work out other situations with people who are known to be infected.
Yeah, so I will say that CDC has released a little bit of guidance on this. I think cohorting is a tried and true attempt by infection prevention and control specialists to place patients who have either the same laboratory diagnosis or the same type of symptoms in at least kind of the same geographic area, so that there is the ability to reuse some of that PPE that, given that it is not soiled or becomes visibly wet or contaminated during an exposure. But I agree with Dr. Fiskus that really would be difficult to enforce in the outpatient setting.
Monitoring temps daily. So I assume you're talking about employees, and you do need to check the employment law around that. We have heard that there can be some issues with employers requiring people to have their temperature checked, so we'd invite you to check with your own legal counsel on what is and is not appropriate there. Here at Department of Health, for people coming into the State Health Operations Center, we just check once a day, and then we have a handy-dandy little sticker.
We do. I have had my temperature checked. I don't have a sticker at the moment.
Move myself 6 feet from Dr. Keaton, who does not have proof that she has been temperature checked. But we just do it once a day here. And we have had folks who have ended up not feeling well since they've been here in the shock and have gone home, and they have appropriately sat out their 72 hours before they have come back to work to make sure that we're not exposing the people who are here in the command center. That would be a really terrible thing if we were to end up with a COVID outbreak within our operations center.
That's correct. The next question is, are we considered a high-risk state? So I will admit that I don't know the latest guidance that's out there on what are considered high-risk states. I will say that we are having more and more cases every day, and I imagine as that increases across the country, some of that guidance regarding travel to specific states or geographic regions may go by the wayside, because the virus is circulating more and more widely every day. So I don't know the exact classification. Dr. Fiskus, do you happen to know?
All I've heard still so far is New York and Washington, but again, as Dr. Keaton said, that changes moment to moment. So if you go to the CDC website and click on the travelers links, that will tell you where the hot spots are. We moved from having just 5 countries last week to having 5 countries plus all of Europe now. So those numbers and that guidance changes quite frequently.
And I will say that there's also guidance that was just released overnight, I believe, saying that Americans really should not travel abroad at this point as well, in case you were not aware of that. The next question that we have is, to conserve PPE, can we wear goggles and masks continuously from patient to patient? So I think that this gets very tricky. I think if you have goggles, those can be worn from patient to patient, provided that they don't have aerosols or secretions on them. So if you were, in direct contact with a patient and they coughed on you and that could have gotten on your mask or your goggles, I would say that those need to be cleaned immediately before seeing another patient. With regards to surgical masks or N95s, that would really depend on the type of exposure. I would check CDC's guidance on conserving PPE. They have some very specific recommendations on when you can go use a mask or an N95 on more than one patient, and I think it's really helpful to review that before you even need to consider that, if possible.
The next question is about false positive and negative rates for the PCR testing that we're doing. And as more labs come on board, the testing may be different from lab to lab. In general, these tests are highly specific, and they generally don't have much in the way of false positive rates, because we're actually looking for RNA from the virus for the coronavirus. So the false positive rate should be quite low. The false negative rate can be a little bit higher, because a lot of that is dependent on the technique. This is not a nostril swab, this is a nasopharyngeal swab, so you got to get that back there and ensure that you're submitting a good specimen. But if we get swabs that are dry, they can't be run, and so you could get a refusal from the lab to run that. Sometimes they are indeterminate results that come back because they didn't meet their threshold to be able to cause something positive. It's also really important that you're using those synthetic swabs because cotton has DNA or our DNA, I guess, associated with it. And you can end up with a falsely positive test if you have a natural fiber that's being used for testing.
All right, the next question we have is, should we wear masks for rounding at nurseries? So I would say in general, no, with a few important caveats. So I think if you are somebody who has had contact with a confirmed case of COVID-19, there is guidance from CDC saying that if there are no other options for healthcare workers at your facility, and you're required to come to work just because there's nobody who can take your place, they are asking that asymptomatic healthcare workers in that situation wear masks when they round on their patients or when they come in contact with patients. If you are otherwise well and have not had one of those contacts, I would say that you do not need to use the PPE or the resources to wear a mask just in general in a nursery.
What kind of gloves are okay? Blue chemistry lab gloves, any kind of glove is okay.
What you would regularly use, I think, in your clinical practice is should be fine for COVID-19. The next question is, what will happen as more and more tests come in and labs get backed up? How can we handle the long times? That is a very great question. My hope is that our capacity will continue to increase as the need for testing increases. Obviously, it will not be a perfect ratio, but I do think even if initially we have seen long turnaround times at labs, we are still seeing relatively short ones. I think as, if labs do get backed up, how will we handling the wait times? I think it's just going to have to be a case-by-case scenario. I think if somebody is able to quarantine at home, that would still be the recommendation, understanding that this is difficult, but I think these are really unusual times that we are in, and I think it's more important than ever to realize that maybe you can put off that meeting, you can put off those appointments, you can cancel appointments if possible. I think both commercial labs and our state public health lab are working around the clock to make sure that they can meet the demand as quickly as possible. But agree that could be a tough situation.
Someone has asked that we list the drive-through testing locations. It's getting to be a fairly long list. So the easiest place to find those are to go to www.tn.gov, and there is a red bar at the top of the page. If you click on that red bar, that takes you to the state's corona page, which is the governor's corona page, and scroll down, and on the left side you'll see a box that says alternate testing sites. Click on that box, and those are listed by county. I don't think there's been any of those sites that have said they won't test children, but a couple of things about that. So first, again, please don't go or send people to a testing site if they are asymptomatic, regardless of their level of exposure. We really need to use what limited testing that we have to test those people who are symptomatic, and we cannot use those resources to test the worried well at this point. Hopefully we'll get to a point where we have unlimited testing capability, but we don't have it now. The other is around children. So there are getting to be a pretty decent number of studies and reports now that show that children by and large are not getting infected with coronavirus. So this is different than what we heard initially, where there were a lot of concerns about children being sort of asymptomatic shedders and spreaders of coronavirus. They did a census census testing of every child in Washington that presented to Seattle Children's, and it was several hundred children that were all symptomatic. They tested every one of them, and I think they had 4 that were positive and 1 that was ended up being hospitalized out of that. So it's, from their numbers, it was around 1% of the children that were tested that were symptomatic that actually had coronavirus infection. So it's unlikely that a child, well, let's say we should consider children to be low risk unless they're in a household where they have a known exposure. It's looking like it's probably more likely for parents to be passing coronavirus to those children than the other way around at this point. So if you have a child that comes in, if you're a pediatrician or you're in family practice, and you are seeing the typical March funk of RSV looking, happy wheezer kind of kids, it's probably more likely that they're going to have RSV, human metapneumovirus, rhinovirus, one of the other more common viruses that we see, than that they would have coronavirus. That doesn't mean don't mask, and I know the challenges of having a mask on a 2-year-old is that's pretty difficult.
Yes.
But if you can have the people who are working for you masked so that they're protected, send a respiratory viral panel on those kids, you'll have that back faster in most cases than you would have COVID testing. You can always have a COVID swab in your fridge that you send should that respiratory viral come back negative and you decide that you think they need to be tested. But in general, we probably don't need to be as concerned about children as we are about adults.
Correct. The next question we have is, what about PPE? Most sites are not able to order new supplies at this point. We hear you loud and clear on this one, and we know that this is a huge problem. So I think in addition to kind of what Dr. Fiskus mentioned in terms of conserving PPE and really looking through the guidance provided on our website at the Tennessee Department of Health, I would also look at CDC's website. They have a lot of contingency and crisis planning for, being out of specific components of personal protective equipment. Another option that I know a lot of folks are not super comfortable with yet, but might be worth considering, are things like telemedicine and telehealth. So CMS has actually relaxed a lot of their regulations on billing and counting these visits as true medical visits. I think if you have a patient who is not urgently ill, or that could potentially be assessed first by phone and triaged by phone, that hopefully will decrease your need for personal protective equipment. And then also, I think it's worth considering, if you are truly out of personal protective equipment, rescheduling any and all appointments that are not urgent. So those would be routine health visits. We're not saying to cancel them altogether, but potentially delay them for a few weeks until the supply chain can really catch up with what's happening.
There's some questions about OB guidance. So a few things about that. So obviously pregnant women are considered to be immunocompromised. We don't have a great deal of data on women who are pregnant and infected with coronavirus to know what their outcomes look like. We also don't have a lot of information about newborns who have been exposed or infected with coronavirus and what their outcomes look like at this point. And yet, despite coronavirus, people are still having babies every day, and we need to know how to deal with that. So if you have a mother who is in labor and is symptomatic, then she needs to be masked, and the people who are around her, attending to her, need to be masked and in PPE if they're in direct contact with her. As far as isolating a baby from a mother who's positive, I think what I've seen so far is to mask the mother and allow her to have access with her baby. That could change, but right now, even around breastfeeding guidelines, it is that if you have a mom who is COVID positive or coronavirus positive, that you would mask her and allow her to nurse her baby. As far as they can tell, they can't detect coronavirus in breast milk. So it's not completely known if a mother can pass coronavirus to her infant through her breast milk, but they've not been able to detect the virus in breast milk. If a mother has an option to pump and have someone else feed the baby, that's another option if you wanted to put some distance between the mother and the baby. For the remainder of the time that mom is in the hospital postpartum, she would need to be in isolation if she's an identified case, with all of the other isolation parameters that happen with people going into the room in full PPE, donning and doffing, and all of those guidelines, just as you would for any other person who's in droplet precaution isolation for the time that she's in the facility.
I will also add that I believe CDC, and I know I'm starting to sound like a broken record, but I think CDC has actually developed specific guidance for pregnant women in the OB setting that might be helpful in that situation. Also, anecdotally, I think China released a study of a small number of pregnant women who became infected with COVID-19 and all went on to have healthy babies. I don't know the data on whether or not the infants tested positive, but in terms of outcomes, I think both mother and babies in that study did very well. So hopefully we'll have more information on that soon. The next question is, are pediatricians more resistant due to exposure to so many respiratory diseases? I think that is a great question, and I would like to think that that is the case.
I would like to think that's the case, too.
Yeah, I don't think we have the answer or the scientific answer to that question. I think there has been a hypothesis that children, at least, who have come in contact with so many respiratory viruses during their lives and through exposures at schools and daycares and that sort of thing, perhaps are more resistant, and that's maybe why they're having better outcomes, but I don't know if we have a whole lot of evidence to back that up at this point.
Where are we on treatment options? Great question. So you've probably heard that there have been some very small studies looking at chloroquine as a possibility. There have been some of the anti-flu medications that have been floated. The good news about those medications is that they're already FDA approved, and so the studies should be able to happen relatively quickly to look at the efficacy of those medications. Unfortunately, I'm also seeing stories, especially on social media, of providers who are just writing scripts for chloroquine for people, which is not appropriate, and we would discourage people from doing that or going out and stockpiling chloroquine when we don't really have data to support that that's going to be something that's helpful. So more to learn on that, and hopefully those clinical studies will happen quickly.
Right, and I will also add that I believe Kaletra, which is historically a drug for HIV/AIDS, is being studied, and I think it's important to remember that all of these drugs, even though they're already FDA approved, do come with significant side effects, and so I think they're reserving those for patients who are really critically ill. I really would not recommend considering those until, one, we have more data, and I think two, if a patient is otherwise doing well, I think supportive care is probably the best option for them.
As a reminder, more than 80% of the patients who become infected with coronavirus do very well and have self-limited mild to moderate symptoms, similar to what they might experience with a seasonal flu. So if we suddenly start seeing scripts going out for chloroquine to everybody who may or may not have been exposed, then we're going to be in a world of hurt when it comes to trying to deal with that 15% or so who become hospitalized or seriously ill.
As a dermatologist who spends a great deal of time in close contact, what should I be doing? Great question. So I think there's a couple of things that you can do, and I've seen a few different examples of this. So I think one is calling patients before they come to your clinic one day and asking them, have they had exposure? Do they have respiratory symptoms? If they have, consider canceling those appointments. Another option, I think, would be to do more telehealth options. Obviously, I know a lot of people are not comfortable with that at this point, but I think if a patient, does not have respiratory symptoms and does not report any of those high-risk exposures, I would think that, your risk would not be significantly greater than it would be otherwise of getting ill. I hope that helps.
When will testing come to more rural counties? So as of now, there is testing available at every rural county public health department. On a limited basis, you'll need to contact those departments to find out what hours they're doing drive-through testing, and that is very limited. So again, not sending people who are asymptomatic and worried well to those types of testing centers. And then very many of the sites that are listed on the governor's website are rural counties. So take a look at that website. There are more and more labs coming on board every day that are able to test, and more local sites. You might want to give your families some guidance and some warnings, though, that there can also be testing sites that are not legitimate testing sites. So they should be very careful about sites that are maybe not listed on the tn.gov website, or where someone's asking for money from them. All the guidance has shown that there will be coverage for these tests by insurance. If someone's uninsured, we can have a test sent to the state public health lab with, if the provider calls us to get permission to send that, to get authorization. So money should not be exchanging hands at any of these sites, certainly not the ones that are run by the public health departments. So just caution folks about anyone who might seem a little bit shady, who might be out there trying to test folks. And we probably have time for one more question.
I'll answer the "Are there any deaths in Tennessee?" question, and the answer is, as of right now, there aren't. That again may change as the day goes on. In terms of, we might be able to get another question in.
That was a short one.
Yeah. So is it true that there's a 30-day shedding after recovery? And I think at this point we don't know. I will say that there is a difference between viral shedding and shedding of infectious virus. So just because a test is able to detect viral RNA on a patient sample does not mean that that patient is actually contagious. So that, even though the RNA may be there, there may not be viable virus that could be infectious to other people. And so I think, this virus was just, really recognized in December of 2019. So some of these answers we just don't have great details on yet.
All right, well, that is our time with you. We did have a webinar last Friday for all of you, and there is a question and answer from that webinar that either has been or will very shortly be posted to our website under the Provider tab. Again, at tn.gov/health, go to the orange bar at the top about coronavirus, scroll to the bottom to the Provider tab, and that webinar link is there. The question and answer will be there, and we'll add some of these questions that we didn't get a chance to get to into that document as well, and update that. And we'll also try to post the link to the information that's come out of Seattle Children's. Some people were asking about that data as well, so we'll try to get that up for you. In the meantime, you can certainly reach out to us at Tennessee Department of Health if there's anything that we can do to assist you further, and let us know if these are helpful. You can make a comment on the Tennessee Department of Health social media sites to let us know that this is something that's helpful for you, and we'd be happy to do more of these to keep you updated as the weeks go on.
All right, thanks everyone. I hope you have a great Friday.
Thank you.